One of the very special things about mental health nurses is their ability to establish professional relationships, working relationships with clients, and utilize therapeutic communication in a way that really establishes and maintains professional boundaries. Our goals is, as caregivers, is to partner with the care receiver to form this therapeutic relationship, and then we can, kind of enter that continuum and support them in healing, growth, and illness prevention. Hildegard Peplow, who's really seen as the mother of psychiatric nursing, asked the question, shall a nurse do things for a patient or with a patient? And really, we, even going back to Orem, our goal should always be to partner with the patient and to help and support them to be as independent as possible. We don't want to transfer the responsibility of their ADLs onto us. We want them to not become reliant upon us. We want them to become self-reliant and able to make a successful transition back out into the community or whatever location they're going to. So the role of the psychiatric nurse includes being a counselor. It's sometimes, you're a stranger, you're a resource person, a teacher, a leader, a surrogate, and a technical expert. The therapeutic nurse-client relationship utilizes a problem-solving model. So remember that all therapeutic interactions or relationships, all therapeutic communication is done with a purpose. So these are the steps of the therapeutic nurse-client relationship problem-solving model. Now, one, you identify the client's problem, and then you promote discussion of their desired changes. And you're going to notice the word change in here a lot because this is all about how to help them grow and improve. Then you're going to discuss the aspects that cannot realistically be changed and ways to cope with them more adaptively. So this is all about stress, right? So what are the things that are stressing them out that they can't come to terms with, and how do they adapt? Discuss alternative strategies for creating changes the client decides or desires to make. So if the client says that I want to be a multimillionaire and live on Mars, and that's not reasonable, then what are some alternative strategies? Weigh the benefits and consequences of each alternative. Help them select an alternative that you feel is safe and reasonable, and encourage the client to implement the change. Provide positive feedback for the client's attempts to create the change, remembering that we don't judge, so you're not going to tell them if they're good or bad, but we do notice, so we do make observations that they have done something positive for themselves, and then help the client evaluate outcomes of the change and make modifications as required. So essentially this is just like the scientific model or the nursing model, but we're addressing stressors and change rather than a problem. One of the greatest tools that you have in the mental health world is yourself. And so a lot of times what you have to do is use yourself therapeutically. So consciously you're going to use your own personality and in full awareness of an attempt to establish relatedness and structure in your nursing interventions. So you are very purposely molding or changing the way that you are acting and interacting with the mental health client to gain a desired outcome. In order to have a therapeutic relationship, you have to establish a rapport and trust and respect. You need to be genuine and you need to have empathy. There are 4 phases of the therapeutic nurse-client relationship. The first one is the pre-interaction phase, and that's where you're looking up information about the client, just getting to know them a little bit and thinking about your own biases. So what are your feelings about them and their case? Do you have any fears about your interaction, or are you feeling anxious at all? So really think about your own kind of pre-arrival preparation before you get to the bedside or before you get to the interview room. How are you feeling about this? And you may think that that sounds strange, but the first time that you have to go in and care for somebody who just, murdered people, or who's a violent rapist or a pedophile, you may find that you have emotions that you need to deal with before you walk through the door. In the orientation or introductory phase, you're going to introduce yourself. You create an environment of trust and create that rapport with the client. You want to establish a contract for intervention, which sometimes is written and sometimes is verbal. And then utilize the nursing process. So do your assessment, create your nursing diagnosis, create your plan, work your interventions. During the working phase, you're going to kind of work through the plan that you've put into place, maintaining that trust and rapport. Veracity is huge here. You need to be honest. Employ good problem-solving skills. Work through those problem-solving steps. Work on and evaluate the goals that the person has. And then watch out for transference and countertransference. So really watch to make sure that neither of you are crossing any boundaries. And if you notice that the person is transferring emotions that they had for somebody else onto you, or if you are experiencing countertransference where you feel like you're overly emotionally connected to the person, then you need to terminate the relationship, tell the manager right away, and get reassigned. In the termination phase, progress has been made toward the goal, and there's a plan of action to continue adaptive coping and handling stress in an effective manner in the future. And so then you say goodbye and think about your feelings about the termination of the relationship and how that went. Remember that every interaction you have with somebody, self-reflection is the opportunity that you have to really think about what you could do different or better the next time. So that's an important step. Nonverbal communication is huge, and it could be easily misunderstood in this client population, so you have to be very careful. Keep in mind that your nonverbal communication has huge cultural implications as well, and what is normal for one culture may not be normal for another. Your physical and appearance and dress says a lot about you. It also says a lot about your client, so take that in. Body movement and posture as well. You should act relaxed and open and friendly, but not too friendly, and certainly not crossing any borders and seeming amorous at all. Keep in mind that people have different interpretations when it comes to touch. Touch carries a very different meaning for different individuals. So be very careful about who you touch and where and for how long. A good rule of thumb is, to maintain minimal physical interaction with a mental health client, even if they're the same gender. Facial expressions, try to be fairly neutral, again, friendly, open, approachable. You need a good poker face sometimes for some of the conversations that you're going to have. Eye behavior. So you'll find that people with certain mental illnesses don't like eye contact. And so you may, glance at them briefly and then look away or down. But if they're uncomfortable, obviously, while you're making eye contact, then you might want to back off a little. Vocal cues or paralanguage, so that's, our pitch, speed, the pressure of the speech, any other vocalization that you're doing, all of that contributes to nonverbal communication. One of the goals while you're a student, and then if you go into mental health nursing, really is to kind of conquer some of your nonverbal communication so that you feel like you're more in control of it rather than it is controlling you. And you can do this by recording yourself and watching it, watching yourself in a mirror, asking a peer or an instructor for feedback, but not the patient. Our book lists a lot of therapeutic communication techniques. It's important to understand why these are therapeutic. The goal of a therapeutic communication is to allow the client to lead the discussion, but to keep it on track and to keep it working towards the goal of whatever that interaction was. When you use silence, and usually that's at a pause during the conversation, you're allowing the client to kind of like regroup and think about things and decide what they want to talk about next, or allowing them to kind of process their thoughts and to keep going. When you use accepting, you're giving positive regard. Giving recognition is acknowledging or indicating awareness. Offering yourself is making oneself available. And that's something, these are all tips and tricks that you should use with, I shouldn't say tricks, techniques that you should use with every patient that you come in contact with, not just mental health clients. Broad openings. So that's allowing the client to select the topic. Good morning, my name is Inge. I'm going to be the nurse taking care of you today. How was your evening? Do you mind if I sit with you for a little while? I have time. So that's offering myself. What would you like to talk about? So that's giving them a broad opening. Or, tell me about yourself. So giving them some, allowing them to kind of select what they want to talk about. When you offer general leads, that's encouraging the client to continue. So those are those little yes, I see, go on. Those are those little verbal cues that you are telling the person, I'm still listening, I'm interested, I'm here, keep talking. Placing an event in time or sequence is an interviewing technique that we use to clarify what happened when, who was where, was this before or after something else, to really make sure that you understand the sequence of events and the relationship between the things that happened. Making observations would be things like, I noticed that you cut your hair, rather than saying, I like your haircut. The difference between those two statements is one is non-therapeutic, saying I like your haircut or your hair looks good like that is giving approval, and that is considered non-therapeutic because they didn't cut their hair to please you, so it doesn't really matter if you like it or not. Versus saying I noticed you cut your hair, it tells them that you you recognize them, that you've made an observation, that you actually see them, and so that's important. You can also use it in terms of I noticed that you didn't eat your breakfast today, or I noticed that you are drawing whatever, trees, or I noticed you're tapping your fingers, or I noticed that you've been pacing a lot this morning. So making those observations, you're not assigning any negative or positive to it. Really all you're doing is kind of opening a conversation about basically hey, I saw this, do you want to talk about it? Encouraging patients to describe their perceptions helps. So, asking them to kind of talk about, so what do you think is going on? What do you think the problem is? What do you think this is? And then encouraging them to compare it to, how is this similar or different than the last time this happened to you? So if you get somebody in who's really sad about, a breakup or something, and you might say, okay, why do you think this is happening? What do you think is going on? What's your perception of the situation? And then how is this different than the last time that you broke up with someone? And it helps them put things into perspective. And a lot of times when you encourage comparison, it helps them remember that kind of life goes on. So even though things may seem really bad right now, they remember that they kind of got through it last time. Those are things we never say to people. So we never give those little pat answers oh, it'll get better, life goes on. But sometimes when we use these therapeutic communication techniques, they're able to see those things on their own. Restating is just kind of restating what they have said so that you're sure that you understand it correctly. And then reflecting is putting the questions or feelings back to the client so that they can be recognized and accepted. So, if they ask you a question like, what do you think I should do? Sometimes just saying, well, what do you think you should do? So kind of putting things back onto them helps. Focusing is where you take notice of a single idea or even a single word and you say like, so I noticed that you, so I'm kind of like making an observation, but then you say like, I noticed that you talked about your dog. Tell me more about your dog. So you're making an observation, but then you're focusing in on that. Exploring is when you delve further into a subject, idea, experience, or relationship. So, some of these are more interviewing techniques for higher level therapists as well. So if you say like, today I really want to talk about X, Y, and Z, make sure though that you're not probing. So you're not talking about something that they're not comfortable talking about. You don't want to ask repetitive questions and try to like force them to talk about something that they don't want to talk about. But sometimes, they'll say, and that's when I tried to kill myself, and you'll say, really? Okay, tell me more about that. Like, when was that? How did that happen? What were you thinking? Did you have a plan? Did you actually have the means? Like, so kind of explore that idea a little bit further. Seeking clarification and validation is when they're being like vague, or sometimes they're having a little bit of flight of ideas and things are moving around a little too quickly for you to follow. And then you want to ask, can you just explain this to me? Or I'm not sure I understood this. Did I understand this correctly? And ask. Presenting reality and voicing doubt are two different things. So presenting reality is when the person is having hallucinations. You want to tell them like, no, I don't see those bugs. I don't hear those voices. Voicing doubt is when a person accuses somebody or something of happening, and you think that that's not true. So like if somebody says, I can't go home because my parents are going to kill me, and you can say like, I highly doubt that that's true. So let's talk more about that. Why do you feel like that's happening? Or what makes you say that? Attempting to translate words into feelings. So putting the words into the feelings the client has expressed only indirectly really is a technique that therapists only use. Nursing doesn't do that much at all. And then formulating a plan of action. And that is used to help prevent anger or anxiety from escalating. So if the person's really stressed about something and they keep saying over and over, like, I want to go home, I want to go home, I want to go home, and you say to them, okay, so in order for you to go home, these are the things that need to happen. This is the order that they need to happen in. I can't get you home right now, but I can get you a shower and some food and, a bed to sleep in for tonight. I can get you in with the therapist tomorrow, and we can get you moving towards home. But formulating that plan of action helps alleviate that anxiety and makes them feel like they have a little more control over what's going on. The book also goes into a lot of the non-therapeutic communication techniques. So false reassurance, everything's going to be fine, tells them that they shouldn't worry. It belittles them. Rejecting, so refusing to consider their ideas. Giving approval or disapproval, we talked about. Agreeing or disagreeing is basically the same thing, but you're passing judgment, and you're not there to judge the patient, and the patient's not there to make you happy. So approval, disapproval, agreeing, disagreeing, like that just doesn't have any place in nursing. It is not ethical or legal for the nurse to give advice. It goes directly against autonomy, so we should never, give the patient advice. Probing is where you push too hard for answers. And then defending, if the client criticizes something, or if the nurse criticizes the client, it basically tells them that they don't have the right to have their own ideas, opinions, or feelings. Requesting an explanation. So sometimes when we're talking to people and we're trying to get information, we will start questions with, can you tell me why this happened? That oftentimes makes people feel defensive. So it makes them feel like they have to justify their behaviors or feelings. But that's something that rolls off the tongue. Like I know even just within the last 5 minutes, I've probably said it 3 times. But if you can become aware of the fact that you say that, then you can also work to find other words. So instead of saying, you know, why did you want to jump off the bridge? You can say, tell me what you were thinking when you were standing on the bridge. Or, you know, I understand that you were thinking about jumping off the bridge. So there's, again, very purposeful choice of words in order to utilize these techniques. If you say what made you, you know, want to hurt yourself, that indicates that there's some sort of external source of power or higher power, and that the person's not responsible for their own actions or behaviors. And that really is not therapeutic, because then they don't take accountability for what they're doing. Belittling, just, you know, pat answers, all of those things really make the person feel like that their thoughts are not significant or important. Making stereotyped comments is meaningless. So everybody feels that way. God needed another angel. You know, you can always have another one. Things like that. Those are like terrible things to say to people. If you don't know what to say and you're uncomfortable with the silence, you should say something like, you know, I don't know what to say. That's an honest statement, and that's going to get you a lot further with someone. Or just saying like, you know, I wish there was something that I could say that would make this better for you, rather than trying to come up with some like Hallmark greeting card expression that's just going to ruin the relationship. Don't use denial. Try not to interpret results. That's what a therapist does, again. And then introducing an unrelated topic. So when you're having a conversation with somebody and the discussion starts to lull, sometimes we change the topic. Sometimes we change the topic because we're uncomfortable with what the person is talking about, and that's non-therapeutic. So if the person, you know, you're in there and you're talking to them and they like say to you, oh, sometimes I'm just so sad I want to die. And you say, so what do you want for lunch? Right? That's completely non-therapeutic. You need to really address the fact that they just said that they wanted to die. But if you were talking to them about their pets or something and the conversation just kind of dwindled, and like there's this silence and then they don't say anything, and now it becomes like an awkward pause, you could ask, what would you like to talk about next? Or you could say, I think I remember that you had, you know, whatever, that you had grandchildren or something like that. Like, you know, you could start a new topic. It's less therapeutic, however, than letting the patient guide the conversation. So introducing an unrelated topic, and truly it's unrelated topic, that makes it less therapeutic, rather than just exploring something or going with the flow of where the conversation was leading you. When you are working with the mental health clients, a lot of times you need to provide feedback. And you need to provide feedback about how they were in a group or, you know, with one other person. And it's important that you provide honest feedback. This is a really good skill for you to develop, because at some point in time, you're also going to be mentoring new nurses. Useful feedback is descriptive rather than evaluative, and focuses on the behavior rather than on the client. So one of the things to remember is that you always have to separate the behavior from the outcome. So if the behavior is good, it's good whether or not there was a positive outcome, and if the behavior is bad, it's bad whether or not there was a positive outcome. So you really want to describe what you saw, and you want to describe the behavior. Don't evaluate the client. So we don't want to use like you did good, you did bad, like you're doing better, you're doing worse. Just say, this is what I saw, and focus on the behavior. It needs to be really specific. It can't just be general. So you can't say, you know, oh, today in group you were much more conversational than normal. that doesn't give them anything. So you need to say, like, I noticed when you were speaking to this person that you were standing very close to them, and to me their nonverbal cues appeared very uncomfortable. Did you notice that they were not making eye contact, or that they kept trying to back away from you? So you want to give them very specific feedback, because they're going to incorporate that then, and next time they're going to try to do better. The goal is to help them modify the behavior so that they can do better. So you want to make sure that the feedback that you give is directed toward the behavior that they actually have the capacity to modify. So if someone has a stutter, you're not going to bring that up because they're still going to stutter. If somebody has autism, you're not going to bring up a lot of the eye contact stuff, because a lot of times they can't make eye contact because it's super uncomfortable. And then you want to impart information rather than offer advice. So you don't tell them how to fix it. You just share your observations. You talk about their behavior, and you help them understand, so to give them time to ask questions, and it should be very timely. So that's the helpful part of feedback. All right, and it can be formal where it's like written, or it can be informal where it's verbal. Active listening is covered in your book as well, and that is where you're listening with purpose and you're paying attention to both the verbal and the nonverbal cues. The nonverbal behaviors that facilitate active listening, or that really help the client understand that you are listening, are those solar techniques. So you want to sit facing the client. Don't sit kind of off to the side so that you're both looking at a wall. Observe an open posture. So again, don't cross your arms over your chest. You want to be open, you want to be friendly, you want to be approachable. Lean forward, not creepy, but just gentle, and that shows that you're engaged and that you're interested. You want to establish eye contact, but you don't have to maintain it. So this is not a staring contest, but you do want to pay attention to them. And really what you want to try to avoid is your eyes darting around the room looking at other people and other things, because once your eyes start to wander, your brain is going to start to wander and you won't be listening. And then try to relax and just kind of enjoy the conversation and see where it takes you. Process recordings are written reports of verbal interactions with clients, and they're written by the nurse or the student as a tool to improve your own personal communication technique. They look at what the student said and their nonverbal communication, how the patient responded, and their nonverbal communication, whether or not the student's attempt at communicating was therapeutic, and then how that student felt about that particular point of the interaction. The process recordings can be used in any setting, not just mental health. They could even be used if you had an argument with somebody and you wanted to go back over and say, how could I have done that better? But really it helps you with both your verbal and your nonverbal communication skills to think about and go back and just kind of analyze where did this break down, or did it go really well? And it helps you think about how could I have worded that differently, or could you have done that differently the next time. Once you start to form a plan for the next time of how would I do that differently, then the next time that will become much more easier for you. So that's the benefit and the purpose of a process recording.